on to the next speaker. Dr. Eric Mallack is director of the leukodystrophy program.
Thank you for having me. So what I intend to do with, how much time do I have? 30-ish minutes? Is to really, what? At least 20 minutes, okay. It's sort of talk through a cross-section of where I think imaging is in cerebral ALD, do a little bit of a review. Some of you probably have seen the slides before, but for learning purposes, we'll talk about them. Some disclosures, but really the goals are to illustrate in this disorder late stage versus early stage cerebral ALD. I can briefly touch on the surveillance recommendations, and then I want to talk about a little bit about some new data, new natural history data that we worked on over the pandemic, and then talk about some novel sequences and imaging research. So the natural history of cerebral ALD has been talked about extensively today. We know it's a devastating disorder. And in terms of transplant outcomes, if you look over to your left, patients who are transplanted while neurologically symptomatic will survive, but generate major functional disabilities over time versus if you look at the survivor curve on the right, patients who are transplanted in the presymptomatic period survive but neurologically retain function. So as we all know, identification of early stage active disease prior to symptom onset is really important. Our goal is to maximize outcomes in childhood cerebral ALD. So this is a bit of a review, but what are the signs of early stage cerebral ALD? Many people have seen slides like this. This is the classic posterior parietal occipital lesion on T2 on the left, and then on the right is the T1 post-contrast image with that garland of ring enhancement indicating that there is cerebral inflammation. So that's advanced disease. We don't want to capture disease there. We want to capture disease here. So this is work that's been out for a few years now, but just to point out, I don't know if there's a pointer. Oh, good. We're looking for disease, oh man, sort of in this stage when the lesion's very tiny. And we know it grows most often from the splenium or the corpus callosum and grows outwards in sort of a spherical fashion. So then here's another example on the sagittal view. We're looking for tiny lesions like this, which have some evidence of lesional enhancement. And this would be the stage at which we'd want to intervene, treat a patient with a stem cell transplant or gene therapy or whatever therapy may be coming down the line. I do want to highlight a real-world example just to say that this is a patient that was referred to me. He was 6 years old at the time. This is his MRI at 5 years, 7 months old. He was a newborn screening kid. And so he came to my attention at this stage. Here's his MRI at 2 years, 5 months old. And you can see here, he clearly has evidence of disease. So the earlier we look, the more we find, and you know, I see my job as trying to find these kids as early as possible. So the question is, so how do we go about monitoring for cerebral ALD? This is the natural history as we know it. Hopefully, you know, with the work of all the advocacy groups here, newborn screening will be instituted across the country. But we find a newborn screening kid. We know that there is lesion onset before there's symptom onset, and then at some point symptoms develop. And so we have a presymptomatic time period, we have a symptomatic time period, and we know, going back to those survivor curves, that when you intervene determines how well you'll do. So the question is, because we've established that there's no genotype-phenotype relationship, how do we go about taking MRIs to capture this time point and then get patients into treatment as soon as possible? So this is work that was put together and published now a couple years ago by Helena Yan and Dr. Turk, who's in this room, doing a meta-analysis of all the known cerebral ALD cases from the literature over the past 35 years. And what we essentially found was the median age of published onset. These are mixed asymptomatic and early symptomatic cases, was 7 years old. which then led to the development of these surveillance guidelines, which recommend getting a scan somewhere between the age of 1 and 2, 2 and 3, but really between the age of 3 and 12, getting an MRI scan every 6 months. There's a lot that goes into something like this, considerations around whether or not you administer contrast, how often you have to sedate the patient, things like that, and the details of which are difficult to sort of standardize across the board. But these are the surveillance guidelines as they stand as of now, and I know Dr. Engelin's going to talk about the international guidelines, which also include surveillance guidelines. And I think over time, as we learn more about early stage disease, we can refine these guidelines further. So this is something new, and this was a lot of this data was curated, collected, analyzed by Anna Torrey, one of your own, who helped me with this project. And we essentially asked the question, well, how long is this? We're not going to do the experiment where we watch kids until they become symptomatic. So we're going to do the next best thing and try to figure out from the time they develop the lesion to the time they developed lesional inflammation, and then how long did it take to actually get to transplant. So you'll see here on the left, when we asked 3 basic questions, it's how we broke down this problem. When do patients develop a T2 lesion? How long does that take for that lesion to enhance? And then from that point, how long has it taken us historically to get a patient to a bone marrow transplant? And then what are the clinical outcomes at each time point? So if we restrict, this data set is restricted to pre-symptomatic patients only. So if you recall from the meta-analysis, the median age of onset was 7. If we looked at just the pre-symptomatic patients as we did in this study, the median age of onset was 6.4 years old. I'll tell you, I didn't put the figure up here, but if you restrict the patients who are identified with cerebral disease with a less score of 1 or less, the median age of onset is 5.9. So really, what we're figuring out is that time period really is shifted. It really is shifted back, which gives us time to intervene. You get, at this point, half a year earlier than what has been published previously in the literature. And if you really capture the kids early, you get 1.2 years worth of lead time. It's a lot of time. So we asked, then the next question was, well, how long does it take for the lesions to develop lesional inflammation? Half of the patients in the cohort had lesional inflammation at diagnosis. So you scan them for their first time, you notice a T2 lesion, and on the T1 post-contrast there was lesional inflammation. The other half didn't. They just had a T2 lesion. So the question was, well, how long did it take? In this case, we call this the delayed cohort. It takes about 6 months for blood-brain barrier breakdown to occur in the patients who don't have lesional enhancement at diagnosis. So what that does is it helps us frame, as a clinician, what are my expectations and how do I frame my surveillance imaging after an index case. So at this time point, every patient we have data for 44 patients. All patients were asymptomatic at this time point. So as you remember, half the patients on their diagnostic scan for cerebral ALD had evidence of blood-brain barrier breakdown. The ones that didn't, it took about 6 months. So if you look at the time point from when lesional inflammation occurred, and you take that time point and make it essentially time 0 across all the subjects, how long did it take us to treat the patients? The answer is about 3.8 months precisely, but 3.5 months. For the people for whom we have data at this time point, 95% of the patients who were identified pre-symptomatically, by the time they got to treatment, they were treated pre-symptomatically. I can make a note about the 2 patients in this cohort who became symptomatic. One was a younger patient who had disease early in life and became symptomatic about 5-6 weeks, which is about the time the patient was transplanted. And one patient was a patient that was in the data set that had evidence of disease, was lost to follow-up, and showed up 2 years later with neurological disease. So we can learn something from the outliers in this case. But in general, the time to treatment for this multi-center cohort was 3.8 months. importantly, I didn't know Dr. Bonkowski was doing this. Dr. Bonkowski did a very similar analysis using a completely separate data set and analytic approach, and he looked at a couple of hospitals on the in the Midwest and on the Western Coast through what's called a FIS database, and he essentially asked the same question: how long did it take from the patients who were diagnosed to actually get to transplant? And what he found was the same answers: 95 days. It's 3.5, just north of 3 months. So that's sort of our benchmark, I think, as a field as to how quickly we're getting these patients from diagnosis to treatment. So what's the, so why do we care? What's the impact? I think these latter two studies are independently validated findings in ALD, which is not something you see often in rare disease, actually having data that's validated, especially using a different methodology, and you essentially get the same conclusion. In neurology, we have this saying that time is brain, and in the stroke world, there's something called door-to-needle time, which is measured heavily in major stroke centers. This is the time from when a patient develops stroke symptoms, they hit the door of the hospital, how long does it take them to get a needle in their arm to get TPA, to break up the clot. So this is akin to our door-to-needle time. It's much, much longer, of course, but I think thinking about it as a neurologist from that perspective is helpful. I think this will help us optimize our surveillance guidelines, and then I think this will help provide some benchmarks for how to design future clinical trials and hopefully demonstrate that we can do better. So I'll spend the last 10 or so minutes just talking about clinical, really neuroimaging research, which is mostly what I work on. And so the question for me is, well, can we use some advanced imaging approaches to help us detect active disease earlier in presymptomatic patients? Some of you have seen this slide. Sometimes it plays, sometimes it doesn't. Let's see if I can actually. Doesn't seem to be playing. That's okay. But this is just showing cerebral lesion growth over time in a singular patient. There you go. So what you can see is lesions grow from the midline of the corpus callosum outward into the parietal occipital white matter. And if you take those lesion volumes and you just sort of map them out over time in an untreated or a pre-treated cohort, what we've essentially figured out is there are patients who progress, as we know, patients with cerebral disease, especially children, have progressive cerebral ALD. What we tried to understand were what were the growth parameters for that, for that growth over time, and how do they compare with patients who spontaneously have self-halted disease or disease that inactivates, which happens about 20% of the time. And so what we figured out was in the patients with childhood cerebral ALD who are going to have progressive disease that eventually then go to transplant, they undergo, the numbers aren't that important but in this case, but they do undergo a degree of acceleration. So if I see accelerating disease on the MRI, that's really indicative that the patient's going to be a progressor. And we can figure that out between 2 scans. And then this last piece here is, well, what's the growth rate? And we did it in terms of fold change over time. So cerebral lesions in active disease should essentially double, or a little more than double every month. And some of these imaging outcomes are being used as investigatory outcomes for clinical trials that are ongoing. But really what I wanted to get to is, and this is what I think is important to parents, if we're going to do contrast, if we're going to do MRI surveillance, do we have to give our kid contrast every single round? And then how do we factor in having to sedate the patients when they're younger? Do we just give contrast because they're sedated and make use of their time? Do we not? So we started looking at different sequences that tell us small differences or differences about the underlying biology of what's going on in the brain. So QSM, quantitative susceptibility mapping, gives us an idea of local microstructure in the brain, but that measurement is actually based off of the little magnetic fields that are generated by either iron, this is used most often for iron, but also myelin, and especially developing myelin. So what I want to point out here is if you look over at this column to the left, Anyway, okay. So if you look at the column to the left, top left is a T2 flare image of essentially just a control. There's no lesion, and then on the left there, that's the T1 post contrast, no lesion, and then that's what a normal sort of QSM MRI looks like. If you look in the middle column, top, you'll see there's a T2 lesion, which is common to cerebral ALD, which is a cerebral ALD lesion, and then in the middle there is evidence of blood-brain barrier breakdown, so that's the contrast enhancement that you see. And then just below that is the QSM image, and you can see there's a little bit of a perturbation in the signal in the midline, but it's still quite dark. If you look all the way over to the right, that is a patient again with a cerebral lesion, but it's inactive. So the panel just below, there's no evidence of lesional inflammation. And if you look on the QSM, the signal's quite bright. So the hypothesis here is, can we use this bottom row to tell us something about what's active versus inactive? And the pie in the sky goal would be to stop having to give kids contrast. So this is one of the goals of the research, and we can expand this to other cerebral inflammatory disorders of childhood. And then so lastly, I've talked a little bit about DTI work in the past, but for everybody, diffusion tensor imaging is also a way to look at local microstructure in the brain. And really, you're looking at degree of organization. And the variable that gets used most often is called fractional anisotropy. That's a long word for how organized is that little area in the brain, and that degree of organization is often governed by how well myelin is packed and organized. So what we did is we looked at a data set of patients with progressive disease and then patients with inactive disease, defined by, well, one, their clinical outcomes, but also whether or not they had lesional enhancement versus no lesional enhancement. And if you can imagine, we all talk about the corpus callosum, the splenium of the corpus callosum. What that really is a bridge of connecting fibers between both halves of the brain. What we did in the patients for whom we have data, we know that most often the lesion starts in the back of that bridge. Sometimes it starts in the front. But we lined everybody up and we said, here's the bridge for this patient, here's the bridge for this patient, and we lined up all of their lesions. And then what we did is take a cross-section of that bridge, and we measured the fractional anisotropy across the corpus callosum, from where the disease was to where the front of the brain, or in some cases the back, the corpus callosum still looked normal. And what you see is on the top, in a patient without progressive disease, but who has a lesion, the slope of that fractional anisotropy across the corpus callosum was either flat or negative. You actually can get a raise or a falsely increased FA value due to gliosis, which is a little bit beyond the scope of this talk. Versus, if you look on the bottom, patients who had inflammatory and active disease, their slopes were positive, meaning that the fractional anisotropy in and around the lesion itself was low and then sort of normalized as you got farther out away from the lesion. And so the idea behind this is, is this another way where we can help decipher who's going to get sick early, try to do away with doing all these extra MRIs that we've relegated ourselves to, and we can just sort of look at how the slope changes. It's a binary outcome. So that's the newest piece of data I got for you. I just want to say thank you thank you to all my collaborators, and I have a lot of mentorship, more people than I can even begin to count. And I'm happy to take questions.
Right, great, thank you. I see 2 hands raised. I think, yeah, go ahead. Yeah.
Thank you. That was great work, and I'm really pleased that you're looking at how quickly you have to move. I mean, total respect in my next question to all neurologists who develop measures in this room. But when you say presymptomatic, isn't it really maybe below the measure of detection? Because we just can't measure everything. And in fact, for all you know, something is going on, you just can't measure it yet. And if you caught it earlier, when you fast forward to this individual in their later life, if they're on the edge of, I don't know, some processing skill, that little bit would give them an edge.
So you're absolutely right, and there's good data that comes from Dr. Pierpont in the Minnesota group looking at neurocognitive issues in early pre-symptomatic ALD. That pre-symptomatic time period, that's the neurologic exam and our history. I will say though, the mother of the patient that I pointed out, that kid had a lesion growing for 3 years, and she suspected nothing. So, and neither did the school. So, I think there is early on, the lesions are so small and they're in these association areas. The corpus callosum's big, and the childhood brain is plastic. So even if you have a lesion in a small area that disrupts some of this cortical connectivity, kids have a way of adapting. Now, yeah, when you get to sort of the closer to the less score of 5, 6, 7, 8, 9, sure. Yeah, I think really careful testing may detect something. But that's not something that's available everywhere.
Question?
Hi, I have a question of clarification.
Mm-hmm.
You said something about from the time the lesion is seen until the breakdown of the blood-brain barrier was 6 months. How that doesn't make sense to me in terms of, like, let's say there's a lesion and it keeps growing. It can grow without contrast enhancement. Am I correct?
Yeah, so that's exactly right. So you're what I want to say is I think these are things that are happening in parallel, and sometimes they happen in series. Your lesion can grow without having blood-brain barrier breakdown. Dr. Mussolino does work on perfusion, showing that you can have alterations in how your blood gets fed to that area of the brain. And even if we don't see it on the T1 post-contrast image, that blood-brain barrier breakdown, there's probably leakage. We're just not capturing it on the MRI itself. Right. And this is only about this, and this is just based on what we know, based on the T2 imaging and the perfusion and this and that. But some of these newer sequences give us better insights into the biology, as do all of these model systems. And what we're probably learning, or I think I'm learning, is that it's highly, highly complex. And so everybody's sort of getting their snapshot of the disease with the tool that they're using, but certainly, yes, the lesion can grow before it really shows that blood-brain barrier breakdown.
Just, sorry, another really quick. Is AI considered part of the symptomatology, or is it, like, so my son had no neurologic symptoms, but he had adrenal insufficiency. Mm-hmm. Is that considered asymptomatic?
When we use the term pre-symptomatic, it's neurologically. Yeah.
Okay, thank you.
I'll just comment on your time to transplant. 3 months is very typical for most centers, and trying to change that, there are circumstances. For instance, the insurance company will dictate your time to transplant given the lead time on approvals. It's often non-medical things that tell us that time to transplant, which is unfortunate. But 3 months is a typical number depending on the center.
Yeah, that's important context, and the factors that go into that timing change. So, long delays can be medical or patient related, earlies can be insurance related. We didn't delve into that, but it's certainly worth talking about.
Hold on.
I actually have a follow-up question to that. And maybe this isn't a great question, I'm a newborn screen parent, and I'm new to this, but wouldn't getting HLA typing potentially done before the need for transplant help shorten that time period between transplant?
It's a good question. I think Troy could probably answer this question better than I can. But lots of things need to happen prior to and doing HLA typing is just one. It's a very important piece of the puzzle, but there's a lot also that goes into this.
The answer is it'll shorten it by 7 days. That's what typing takes, is 7 days.
Are you also looking at neurochemicals, imaging of brain metabolites, and how that's influencing the disease?
I'm not using the imaging modalities that I presented, and I'm not doing that personally. I know MR spectroscopy has been investigated in cerebral ALD. I think more promising is the neurofilament light chain serum and CSF biomarker work that's being worked on by multiple sites.
Hi, Eric. Thank you for that great talk. I love looking at the earlier stages of the disease, so the presymptomatic stages, and things that change before we know what's really happening. I love that you go towards FA. Have you considered other things like free water measurements as earlier potential neuroinflammation measurements than gadolinium enhancement, or other types of white matter integrity measurements as well?
Yeah, so great question. Absolutely. So I mean, we can pull all six eigenvalues out and generate any variable we want. And then the other part is we are looking at myelin water fraction. That's the other modality.
Excellent. Is that going to be published anytime soon? I'm sorry. I'm very interested in data.
As fast as I can. Yeah, as fast as I can.
Excellent.
Yeah.
Thank you.
Go fast. Go fast. You first. All right.
Hi. I know you're a little concerned about the MRIs every 6 months, but I'll share a little bit of my story with you. My son, he was 3.5 years old. He had been monitored since birth, and he was in the Lorenzo Zile study. So he was seen at Kennedy Krieger, and he had an MRI starting at 2 years old. At about 3 years and 5 months, he had an adrenal crisis and rushed to the emergency room. Because of his older brother, I knew what it was right away. And doctors assured me everything's fine, don't worry, kids throw up like this and get sick all the time. And Dr. Raymond was consulted. He said, have an MRI done and test him for adrenal insufficiency. They tested him for adrenal insufficiency. Said, no, we don't think so, but we'll put him on just because of your history, a little hydrocortisone. And the doctors and radiologists read the MRI and said there was nothing on it. And that was it. And then I had my follow-up appointment 5 months later with Dr. Raymond. And he had gotten the written report from the doctors, but they never sent him the images. It was one of those things, and I always tell every parent, make sure they get the images as well. Long story short, he looked on that image and there was a lesion. And it was there 5 months prior. And within that, it had grown, it had tripled in size. So that was just 5 months. Mm-hmm. So when you talk about that 6 months, sometimes it can make a difference with something like the adrenal insufficiency. That can, I'm not sure the chicken or the egg. Dr. Lung never could explain that to me, which came first. Mm-hmm. Prior to that, he was asymptomatic. Mm-hmm. And, he was symptomatic and we didn't know it.
Right, so one of the reasons I point out the outliers are that 6 month to blood-brain barrier breakdown. There's 50% of the patients were less than 6 months that developed lesional enhancement. That middle mark is just the median, it's the 50th percentile. So half the patients developed lesional enhancement and inflammation in less than 6 months. And then half of the whole cohort had it right at diagnosis. So we do know that the disease can progress. It can progress quickly, and our volumetrics tell us that it accelerates over time, which reflects your experience. And so, I agree with you. Always get your images and have them reviewed.
I think it may have been an exception to the rule because even at that stage, he was just here this morning, but he's 18 and doing as well as he expected. Mm-hmm. But at that time, we were told to watch your children like a hawk from the age of 4 to 10. And he was 3.5 months, not even quite 3.5 months. So, I was ready and I was watching. So when I knew when he had that, because I had prior experience seeing him going in to have the adrenal insufficiency, I knew. I was almost hysterical in the emergency room. They was like, no, he's fine, don't worry, don't worry. It's not that. You do not need to worry about him till he's well past 4. Mm-hmm. And, but anyway, thankfully, that gut instinct kicked in. And,
so thank you for sharing, and I think this is the goal. The earlier we look, maybe some of the more refined, but it buys us time.
Maybe last question.
We've been mentioning timelines, and it seems like the 6 months turns into 4 months, turns into 3 months. What is the recommended time period between MRI scans that can confidently be done?
Sure. So,
Or
I mean, the
monitoring.
recommended time and the highest time point between 3 and 12 is every 6 months. The timing that I outlined thereafter is what is the timing of events in the event that you detect a lesion. So, I think for surveillance, you know, the general consensus is every 6 months. I think doing it more than that is hard for things like insurance reasons. On top of it, it's almost hard enough to get normal surveillance done. Yeah.
All right.
All right. Thank you very much.
Thank you again.